Thank you, Dr. Dreisner. Appreciate those words of welcome both from Dr. Dreisner and Ms. Haslam. We're going to move now into our main plenary session speakers. We're going to continue a trend. Ms. Haslam said she had been in her role about a year and a half. We know Dr. Dreisner has been in his role for 1 year and 1 day, but our next speaker has been in his role even less than that. So we are very fortunate today to have Dr. Michael Liu, who is the Associate Administrator of Maternal and Child Health at the Health Resources and Services Administration, HRSA, as many of us call it, and he took that role on November 3rd, 2011. And I can tell you in the MCH world, folks were incredibly excited when the buzz started that he was going to be in that position, and I think we've all been very excited ever since because of his leadership and the energy he has brought to that role. The mission of the Maternal and Child Health Bureau of HRSA is to provide leadership in partnership with key stakeholders to improve the physical and mental health, safety, and well-being of mothers, children, and families. Through the Title V program, MCHB serves 40 million women, infants, children, adolescents, and their families each year, including fathers and children with special health care needs. And since we've just gone through our annual Title V MCH block grant review at the state level, we want to thank Dr. Liu and MCHB for that continued program that supports so many vital efforts here in Tennessee. We welcome you, Dr. Liu.
Good morning. I'm delighted to be here and very honored to be invited to speak at the summit. I'm going to be talking about the Secretary's call for a national strategy to address infant mortality, but the real reason that I'm here this morning, the reason that I'm flying in and out of Nashville in 1 day is to come here and give thanks. First of all, I want to thank the First Lady for her support, and to Dr. Dreisner and Dr. Warren for their extraordinary leadership in MCH in Tennessee. I'll talk a little bit more about the work around the infant mortality COIN, but I just want to thank the members of the COIN team. These are the folks that came to the DC meeting back in July. I'm sure there are other members who weren't able to travel. But I want to give two special thanks to Kathy Taylor, who's the Dean of College of Health Sciences and Nursing at Belmont University, who's also the co-lead of one of our COIN teams on smoking cessation. Now, that team has came up with the goal of reducing smoking rates among pregnant women by 3% over the next 18 months, not just in Tennessee, but across all 13 southern states. Now, I know 3% may not sound a whole lot to you, but just think of the prevalence of smoking during pregnancy and its impact on preterm birth, low birth weight, infant mortality. If they are successful, the impact of their work can be very huge, and under Dr. Taylor's leadership, I'm sure that they will be successful. And the other person that I really want to come here and thank personally is Dr. Kim Waichi Etheridge, or Dr. Kim, who, for all her great work, first with the birthing project, and also as chair of the board of City Match, and now with Project Blossom, and also with the COIN team. She reminds me of what Dr. Martin Luther King Jr. said about human progress. He said that human progress neither automatic nor inevitable. Every step toward the goal of justice requires sacrifice, suffering, and struggle, the tireless exertion and passionate concerns of dedicated individuals like yourselves. So I want to come here to thank you all for your work, and I'm proud and humbled to be standing side by side with you all in this fight against infant mortality. So let me talk about the Secretary's call for a national strategy on infant mortality. As you are probably all aware, Secretary Sebelius announced at a global summit on child survival back in July that we're going to be creating the first ever national strategy to address infant mortality in our nation. This is what she said. Here in the U.S., we've seen our infant mortality rate steadily decline. This is thanks to cooperation between federal and local governments, community and faith organizations, and the private sector. But today, we still lose far too many children in the first years of their life. They've gone before they learn to walk or talk, before they throw a ball or give their first smile. The United States government has committed to protecting the health of our children with targeted interventions serving populations who need them most. We've focused on reducing the number of preterm births. We've set a national goal, very similar to the kinds of goals you're setting here, to bring the percentage of all preterm births down to 11.4% by 2020. To reach that goal, we've launched a nationwide public-private partnership to raise awareness about the importance of bringing pregnancies to full term. We've taken a family-oriented approach that educates women and their doctors on the dangers of premature birth. And we're funding innovative strategies like maternity medical homes, where pregnant mothers receive coordinated care from psychological support to education on how to care for infants. We have learned that seemingly simple interventions can help reduce preterm births among women at greatest risk for poor pregnancy outcomes. And where infant mortality has taken the highest hold in the U.S., we're also partnering with state officials to create strategies and interventions to begin to bring these rates down. Our plan is to find out what works and scale up the best interventions to the national level. And today I'm pleased to announce my department will be collaborating in the next year to create our nation's first ever national strategy to address infant mortality. Now, this is big. Okay? It's historic. The last time we had this kind of national resolve on infant mortality, I was still in medical school. Okay? That was back in the late 1980s, early 1990s, and that resolve led to a vast expansion of Medicaid coverage for prenatal care. Now, this time the Secretary's call didn't just come out of nowhere. It really built on the groundswell of initiatives at the federal, state, and local levels that's been growing over the last several years. First, the March of Dimes started with the prematurity campaign, and then the ASTO, the Organization for the State and Territorial Health Officers, along with the March of Dimes, really sparked a national movement that's now spreading like a wildfire. 49 states, the District of Columbia, and Puerto Rico have now taken the pledge to reduce prematurity rates by 8% over the next 3 years. CMI also launched the Strong Start initiative earlier this year, and we at HRSA launched the Infant Mortality Collaborative Improvement Innovation Network in Regions 4 and 6, including Tennessee, earlier this year that I'll talk to you a little bit more about later on. And all of these efforts at the national, state, and local levels have contributed to a steady decline in infant mortality nationally, about 3% per year over the last 4 years straight. Now, if we can keep this up, okay, we might actually get to 5.5 by 2015 and 4.5 by the year 2020. Now, imagine that, the United States with an infant mortality rate of under 4.5 deaths per thousand live births by the year 2020. Okay. So there's we're at the beginning of a national movement, and you're playing a big role, okay, in starting that national movement, okay, that's now sweeping across the nation. I think the Secretary's call for a national strategy is indeed very timely. And who better to advise the Secretary on that national strategy than the Secretary's own Committee on Infant Mortality? Okay. Now, the SACM is actually an independent body that represents diverse stakeholders, diverse interests, diverse perspectives, both federal, state, and local, public and private, providers, patients, consumers, public health, academia, health plans. And SACM also brings together all the various federal agencies that are working to address infant mortality. And it's that kind of diversity that's needed to create a national strategy, a vision that's broad and encompassing enough beyond narrow interests, beyond single issues, to be called a national strategy. Now, although SACM is an independent body that reports directly to the Secretary, because HRSA, and specifically the Maternal and Child Health Bureau, is the administrative support for SACM, so I've been privy to the progress of the work of SACM in developing this national strategy. So, and while it's still a work in progress, let me highlight some of the key strategies, key priorities that they've identified. And we'll start with improving women's health before pregnancy. Now, this is going to be the game changer, the difference maker this time. For over 2 decades, prenatal care has been the cornerstone of our national strategy for reducing infant mortality. And all the federal and state efforts in the late 80s and early 90s to expand Medicaid coverage for prenatal care led to a significant improvement in prenatal care utilization, but unfortunately not a significant improvement in birth outcomes. Now, this is not to take anything away from prenatal care. It's necessary, but not sufficient. Today, many of us are beginning to recognize that to really improve pregnancy outcomes right here in Tennessee and around the nation, we gotta start by improving women's health before pregnancy. Since 2005, CDC, along with HRSA and other partners, have led a national movement to improve preconception care and preconception health and healthcare in the United States. The Office of Minority Health has also launched a campaign to promote preconception health through peer education, predominantly in communities of color. Recently, CMS, Center for Medicare and Medicaid Services, convened an expert panel on interconception care. I know a number of states are interested in looking at Medicaid waiver, although Georgia right now is the only state that has that 1115 waiver to provide interconception care. With the Affordable Care Act beginning in August this year, with implementation of the clinical preventive services for women, millions of women are going to gain coverage to health care even when they're not pregnant, including coverage for preconception and interconception care without copay, and that provides an extraordinary opportunity to improve women's health, not only during pregnancy, but before pregnancy, between pregnancy, beyond pregnancy, and indeed across their entire life course. Second, to promote quality and safety in perinatal health care. This is where we've made the most progress over the last few years around reducing elective delivery of less than 39 weeks. But there's still certainly plenty of room for quality improvement, such as promoting appropriate use of 17P, improving screening for asymptomatic bacteriuria or GBS, or reducing central line infections in the NICU. And we know that better care can lead to better outcomes and lower costs. Just look at what's happening in states like Tennessee and Kentucky and Ohio and Texas. And just in Louisiana, for example, with adoption of a few simple CQI measures, quality improvement measures, to reduce elective deliveries, they've been able to reduce their NICU admissions by 22% in the last 6 months. So better care, better outcomes, lower costs. Third, invest in prevention and health promotion. This is another area where we can do a lot better, where there are still way too many missed opportunities to reduce infant mortality through prevention and promotion, such as smoking cessation, safe sleep, breastfeeding, immunization, and family planning. The committee is also talking about new workforce, including a team approach that includes community health workers and doulas, a new platform such as group prenatal care, new technologies such as Text for Baby. Fourth, to promote service coordination and systems integration. Now, the committee is talking about integration along 3 dimensions: vertical, horizontal, and longitudinal. Vertical integration in terms of appropriate levels of care, horizontal integration in terms of service coordination and systems navigation, not only within healthcare, but across systems in WIC and social services community programs, and longitudinal integration in terms of that care continuum across the life course. That's what perinatal regionalization is all about, right? Making sure that high-risk moms are delivered or are cared for in hospitals that are equipped to take care of high-risk moms, and high-risk babies are born in hospitals that are equipped to take care of high-risk babies. That's what our home visiting programs are all about, providing service coordination and systems integration, not only within healthcare, but across systems. That's what the maternity, medical home, and birthing centers that CMMI Strong Start is currently testing. And that's what the Navigator and ACO and community accountable care systems are trying to do. Okay? They're trying to use payment innovations to drive systems integration. 5 is to strengthen surveillance and support research. Okay? We're now in 2012, and we still can't get all the states to use the 2003 birth certificates. Okay? We got to work on standardizing vital statistics. We got to work on improving data linkage capacity in the states, okay? Such as linking vital statistics with Medicaid claims data. And we got to figure out how to better promote quality improvement using real-time data to drive real-time improvement. Okay? And while we know enough to act today, there's still a lot that we need to learn. So we got to support more research, especially more translational research around disparities in infant mortality. I'm not just talking about the T1 to T2 from bench to the bedside, but more important, the T2 to T3 bedside to curbside, or T3 to T4 curbside to policy, so that we can help accelerate translation of knowledge to practice and policy. And last but not least, to promote interagency, public-private, and multidisciplinary collaboration. Okay? If we're going to win this fight against infant mortality, we can't work in silo. Okay? I think our current effort around the COIN, the Collaborative Improvement Innovation Network to Reduce Infant Mortality, serves as a good example. Okay? This is a partnership among HRSA, ASTO, NCHIP, CDC, CityMaps, CMS, March of Dimes, the National Governors Association, the National Priority Partnership with the states. Okay? And it really began as a summit back in New Orleans in January, much like a summit like this. Okay? And the 13 southern states brought their state teams, which in most cases included the state health officers, the Title V directors, the Medicaid directors, and in some states, the key staff from the governor's office, as well as the state legislature, public and private leaders. In essence, all the people who could really do something about infant mortality in their states. And the state teams went to work. They developed their state plans to reduce infant mortality. And in reviewing these state plans, 5 common strategies emerged. Okay? These include reducing elective delivery at less than 39 weeks, expanding interconception cure in Medicaid, reducing SIDS and SUID by promoting safe sleep, increasing smoking cessation among pregnant women, and enhancing perinatal regionalization. Now, what was also clear from that summit was that the states actually had a lot of interest. They show a lot of hunger in learning from each other. Okay? So how did Georgia manage to get its 1115 waiver for interconception care? How did North Carolina manage to build a statewide network of pregnancy medical homes? Or what was Texas or Louisiana or Kentucky doing around reducing elective deliveries? Now, the 13 states shouldn't have to reinvent the wheel 13 times. So we thought that at HRSA, we would bring the whole science of collaborative improvement and innovation to help support this effort. So we created a COIN, Collaborative Improvement and Innovation Network, that's organized around teams. Okay? So one team for each strategy. So we got 5 teams, and one of the teams I mentioned earlier, the smoking cessation team, is led by Dr. Kathy Taylor. So we got 2 or 3 leads for each team that are content experts from the region. But the team is also supported by method experts, data experts, shared workspace, and a data platform, a data dashboard that can provide real-time data to drive real-time improvement. And the team's been working hard over the last several months, okay? Mostly in cyberspace, okay? But we brought them together face-to-face for a meeting in July, and they're currently working on their aims, their strategies, their metrics, their driver diagram. These are some of the aims that these teams are working on. Okay? To reduce elective delivery by 39 weeks, less than 39 weeks by 33%. As I mentioned, reduce smoking rate among pregnant women by 3%, increase safe sleep practices by 5%, increase mothers delivering at appropriate facilities by 20%, and change Medicaid policy and procedures around interconception care in at least 5 to 8 states. Okay. So what's next for COIN? Well, we're going to be scaling this up to a national initiative by next year. And we're also going to be learning to better coordinate and collaborate with other initiatives like the Strong Start or the Healthy Babies Initiative. Okay. And that's exactly what we did when the leadership of HRSA and March of Dimes, ASTO, and NCHIC came together last week, okay, for a meeting. That's exactly what we talked about. How do we learn to work better together? Okay. And there's still a lot that we got to figure out in terms of how to coordinate these different national initiatives. But one thing that's clear to all of us is that if we're going to win this fight against infant mortality, we can't work in silos. Okay. We got to come together, public and private, federal, state, and local, okay, across states, across regions, and really across party lines as well. Okay. Democrats and conservatives, okay, Democrats and Republicans, okay, liberals and conservatives. Okay. We care as much about infant mortality in the red states as we do in the blue states. Okay. E pluribus unum, out of many one. That's how we're going to succeed. That's how we're going to win this fight against infant mortality. So let me just conclude with one final thought about infant mortality. If you think about it, infant mortality is really more than just an accounting of infant deaths. Okay. And it's also more than just simply an indicator of community health or social inequality. Ultimately, infant mortality, especially that infant mortality gap, is a measure of how much we fail the greatness of this nation. It's a greatness that's summed up in a simple declaration some 236 years ago. That we hold these truths to be self-evident, that all men are created equal, and they're endowed by their Creator with the unalienable rights for the pursuit of life, liberty, and the pursuit of happiness. And it's a greatness that's made with the simple promise that everyone gets a fair shot, no matter where you're from, or the family that you're born into, or the color of your skin. And it's a greatness that's told in simple dreams, as we tell our children when we tuck them in the night, that when you grow up, you get to be anything you want to be. Well, America gave me and my family that chance. Those of you who know my story know that my parents will probably never get invited to give a talk at a summit like this because they never went to college. In fact, in my mom's case, she never went to high school or even junior high. See, my mom was only 11 when her father died, and so as the oldest girl, she had to drop out of school, drop out of 5th grade to go work in the factory to help support the family. So I didn't come from an educated family or a wealthy family, but that didn't really matter. It didn't matter because in a great America, you don't have to be rich to go to the best schools. It didn't matter because in a great America, everyone gets a fair shot, no matter where you're from, the family you're born into, or the color of your skin. And it didn't matter because in a great America, I knew that if I just work hard enough and try hard enough, I can give my girls a better life, the kind of life that my mom would never even dare dream of. And that my 2 little girls, that's Sasha on your right, her baby sister Avery, who wants to make sure you all know that she's not a baby anymore. She actually had her 7th birthday this year, but I keep using the slide, so she made me put in the slide now. And that's Dora on your left, who's still unrelated, still looks exactly the same. If my 2 little girls, the granddaughters of a girl who had to drop out of 5th grade to go work in the factory, can now grow up in a nation where they can be anything they want to be, that's a true testament to the greatness that is America. If my girls can get that chance, why shouldn't every child born in America get the same chance? If my girls can get a fair shot, why shouldn't every child get a fair shot? This is what we're fighting for, right? It's not just a fight against infant mortality. Ultimately, this is a fight for what we are as a nation. Now, the Maternal Child Health Bureau has been fighting this fight for 100 years, dating back to the establishment of the Children's Bureau back in 1912. Now, I'm proud and humbled to be leading the Bureau in this fight now, and I ask you to join me. If you believe in America's greatness, if you believe that every child should get a fair shot, please join me in this fight. Okay? Let's close the gaps once and for all, and let's win this fight against infant mortality in Tennessee and in our nation. Okay? Thank you very much.